Hello, today we'll talk about non-communicable diseases, and specifically we'll be talking about two very common non-communicable diseases, that is diabetes mellitus and cancer. So first we'll talk about introduction to diabetes mellitus, its pathogenesis and management, and secondly we'll talk about what is cancer, its introduction, pathogenesis and management, that is drug therapy for cancer. So what is diabetes mellitus? Diabetes mellitus is the most common of all the endocrine disorders, and it is a chronic condition which is characterized by hyperglycemia, that is an increase in blood glucose concentration, and it can be due to impaired insulin secretion with or without insulin resistance, meaning that this hyperglycemia can be due to a decrease in secretion of insulin by the pancreas, or uh, it can be due to insulin resistance, meaning insulin is there but it cannot act on its receptors and glucose cannot be taken up by the cells even in the presence of insulin. So this insulin deficiency or insulin resistance leads to hyperglycemia because cells cannot take up glucose, and as a result of which glucose accumulates in blood. Diabetes mellitus can be classified according to its etiology. So type 1 diabetes is insulin dependence diabetes mellitus, while type 2 diabetes is non-insulin dependent diabetes mellitus. So the basic difference here is in type 1 diabetes mellitus, there is insulin deficiency. So giving insulin injections results in treatment of the disease. On the other hand, in type 2 diabetes mellitus, it is non-insulin dependent diabetes mellitus, meaning it does not depend on the amount or concentration of insulin, and even if we give insulin injection to these patients, diabetes is not relieved. So pathophysiology here is that 1 diabetes mellitus is characterized by destruction of insulin producing pancreatic beta cells, and uh, this can occur due to autoimmune T cell mediated destruction, or it can be idiopathic. So here what happens is that the beta cells present in islets of Langerhans of pancreas, they are destroyed, and this can be due to either autoimmunity, that is antibodies are generated against these beta cells, so the cells are killed, or it can be idiopathic. And it usually develops in young people, that is those below the age of 30 years develop type 1 diabetes mellitus. So often we see that even small children less than 5 years of age can be diagnosed with type 1 diabetes mellitus because they inherently somehow they do not produce insulin to the desired levels. And in cases where this destruction is slow, the symptoms start appearing somewhere in the teenage or early 20s. So by 30, most of these patients are diagnosed with having diabetes mellitus. And it can develop at any age and is usually associated with faster onset of symptoms leading to dependency on extrinsic insulin for survival. So in this case, mostly the cases are diagnosed at an age below 30 years, but it can develop at other ages also, and the onset of symptoms is rapidly seen in this type of diabetes. And extrinsic insulin, meaning insulin injections, have to be administered. On the other hand, type 2 diabetes mellitus is more common above the age of 40 and is caused by relative insulin deficiency and insulin resistance, meaning that in this case there uh, is a relative decrease in insulin levels, and there is also insulin resistance. Insulin resistance is uh, a case where insulin is present, it may or may not bind to its receptors, and as a result of which the glucose is not taken up by the cell. So even in presence of normal levels of insulin, glucose does not enter the cells. Etiology of these two types. So type 1 diabetes is characterized by beta cell destruction, which can be autoimmune or idiopathic. Type 2 can range from uh, insulin with relative insulin deficiency, or there is a secretory defect with or without insulin resistance. Meaning, secretory defect means beta cells may release or may not release adequate amounts of insulin, and there can be other uh, specific issues. For example, defects in beta cell function. There can be genetic defects in action of insulin, diseases of the pancreas, endocrinopathies, drugs, etc. So all of these can contribute to diabetes mellitus. Now talking about type 1 diabetes mellitus, due to genetic disposition, environmental factors like viral infections, autoimmune destruction of beta cells in Langerhans occurs, and this leads to an absolute insulin deficiency. So hyperglycemia occurs, and this can lead to diabetic coma, meaning the glucose level becomes so high that a person goes into a state of coma, and this generally happens when the glucose levels cross a range of somewhere around 400 or 500 milligrams per deciliter of blood. Then diabetic coma occurs. Below those concentrations, we see that over a long duration of this disease, micro or macro angiopathy can occur, meaning there is damage to the small and the large blood vessels. Then organ damage can occur, that is retinopathy, damage to retina can occur, nephropathy, neuropathy. So nephropathy means damage to kidney is happening, neuropathy means damage to neurons is happening, myocardial infarction and stroke can happen, and peripheral artery diseases can also occur. So all of these uh, occur in type 1 diabetes mellitus. Now looking at the differences between type 1 and type 2 diabetes mellitus, in type 1 there is destruction of beta cells, and in type 2 beta cells are not destroyed, the number remains constant or unaltered. uh, islet cell antibodies are present in type 1 diabetes, but they are absent in type 2 diabetes. There is a strong genetic link in type 1 diabetes, but uh, the link is even stronger in type 2 diabetes mellitus. The age of onset is below 30 in type 1, and it is above 40 years of age in type 2 diabetes mellitus. There is faster onset of symptoms in type 1 and slower onset of symptoms in type 2 diabetes mellitus, and insulin has to be registered in type 1 diabetes, but in case of type 2 diabetes, insulin is not given. The patients are advised to go for a control in diet and use some oral hypoglycemic agents. In type 1 diabetes, patients are not overweight, but in type 2, patients are usually overweight. And in type 1 diabetes, extreme hyperglycemia causes a condition called diabetic ketoacidosis. But in case of type 2 diabetes, extreme hypoglycemia causes hyperosmolar hyperglycemic state. Now coming to symptoms. The symptoms of these are, the two types of diabetes are the same. They are similar, and they differ only in their intensity. That is, the symptoms are more severe and they appear faster in type 1 diabetes as compared to type 2 diabetes. In type 2 diabetes, the symptoms are relatively mild and they slowly increase over a duration of several months or years. So the common symptoms are polyuria, that is increased urine production, polydipsia, meaning there is increased thirst, so the person will be always feeling thirsty and would like to take water. There is fatigue, there is a weight loss, there is blurred vision, and there is a higher infection rate, and urinary tract infections can also occur. Diagnosis. So first we diagnose the patient based on the symptoms. That is, the person complains of polyuria, that is frequent urination is there, polydipsia, that the person is always thirsty, and there is an unexplained weight loss. Now along with these symptoms, when we see that the fasting serum glucose concentration is above 126 milligram per deciliter, then we say the person is diabetic. Or when we administer glucose to a patient, 75 gram anhydrous glucose is given, and after 2 hours a blood sample is taken, and then serum glucose level is above 200 milligram per deciliter, we say that the person is diabetic. So this oral glucose tolerance test or serum glucose concentration after fasting are two tests which are commonly used. With no symptoms, at least two glucose test results show values in the diabetic range on 2 different days. Now, sometimes it so happens that the person do not complain of any symptoms. Uh, so, in those cases, we take glucose blood samples on 2 different days, and on these 2 different days, the the glucose levels are increased on both the days, then and they are in the diabetic range, then we say that the person is diabetic. So other tests that are used are glycosylated hemoglobin or HbA1c, glucose tolerance test as we talked about. Insulin levels are also determined, and there are additional tests which are done, for example, liver, kidney, eyes, etc. Now these additional tests on liver, kidney, eyes, etc., they are done to check for the complications that may arise due to diabetes. So this table shows what are the diabetic levels, what are the pre-diabetic levels, and what are the normal levels. So if we look at the normal levels, HbA1c or the glycosylated hemoglobin level of approximately 5.7%, a fasting plasma glucose concentration of less than 99 milligram per deciliter, and OGTT showing less than 140 milligram per deciliter of glucose, the person is said to be normal. HbA1c below 6.4% or plasma glucose level under fasting conditions between 100 and 125 milligram per deciliter, or OGTT showing 140 to 199 milligram per deciliter of glucose. This leads to a pre-diabetic condition. Now, if the patient follows strict instructions, the person may come back to normal levels in case of type 2 diabetes mellitus. In case of type 1 diabetes mellitus, this may not happen without giving insulin. But in case of type 2 diabetes mellitus, the person can revert back to normal if strict physical activity, diet control, and other measures are followed. Now, HbA1c above 6.5%, fasting plasma glucose level above 126 milligram per deciliter, oral glucose tolerance test showing more than 200 milligram per deciliter of glucose uh, means the person is diabetic. So this is again the same thing as shown in the table below in the previous slide. So fasting blood glucose level, HbA1c or OGTT is high on 2 occasions, then the patient is considered to be a diabetic patient. Diabetic complications, neuropathy, retinopathy, hypertension, abnormal ECG, nephropathy, diabetic foot, infected diabetic foot ulcer. So all of these are complications associated with diabetes. So indicating that diabetes affects almost all the major organs of the body. A drug therapy for type 1 diabetes mellitus. So in this case, the disease is occurring because of insulin deficiency. So the obvious choice here is to administer insulin. So insulin is the only treatment available, and there are different types of insulin formulations which are available in the market. So they are fast acting, intermediate acting, and long acting. Now the fast acting ones, they appear in circulation within 10 minutes after subcutaneous injection. So subcutaneous means we inject the insulin below the skin. So here when we inject, within 10 minutes of injection, the insulin is detected in blood. So that's why they are called fast acting insulins. They are also called soluble insulins or neutral insulins. Then there are intermediate acting insulins. Now they take much more than 10 minutes for insulin to come in circulation. So when we give these kind of insulins, uh, they appear in blood after a few hours. So conventional intermediate acting insulins are insoluble cloudy suspension of insulin complexed with either protamine, which is called NPH insulin, or isophene insulin, or they are complexed with zinc, which we call as a lente insulin. So these insulins, when injected, they start appearing in circulation somewhere between 2 to 6 hours of injection. Long acting insulins, they have a duration of action of about 24 hours. So this picture shows an example of how a subcutaneous injection is given. For type 2 diabetes, there is no insulin deficiency, or there is little insulin deficiency, but there is insulin resistance, meaning insulin is there but it cannot act on the receptors, or even if it can bind to its receptors, glucose uptake does not happen. So in this case, we give oral hypoglycemic agents. So there are biguanides like metformin and fenformin. There are sulfonylureas like glibenclamide, glipizide. There are thiazolidinediones like pioglitazone, rosiglitazone, and there are several other classes which are also used, but to a relatively lesser extent. Cancer is the uncontrolled growth of abnormal cells anywhere in the body, and this is a group of diseases involving abnormal cell growth with the potential to invade or spread to other parts of the body, meaning that there's an uncontrolled growth of cells in the body, and this abnormal cells which are generated, they can spread to other body parts, or they may remain localized at one particular site. So metastatic tumors are those which spread to other body parts by a process called metastasis, and on the other hand, benign tumors are those which do not spread, and they are contained only in a tissue where they originate. They do not spread. So this picture shows the difference between a benign tumor and a malignant tumor. In a benign tumor, the tumor cells are encased in a capsule-like structure and they do not move from the site of origin. But the malignant tumor cells, they come out of the capsule and they start spreading to other body parts, to other tissues. Classification of tumors is done based on the type that the tumor cells resembles and is presumed to be origin of the tumor. So when we look at the tumor cells under a microscope, we see certain features, and based on those features, we try to say that this particular cell resembles a neuron or a nerve cell, this particular tumor cell resembles a muscle cell, this tumor cell resembles an epithelial cell. So based on that, we try to find out the presumed origin of the tumor. So based on those microscopic features that you observe, they can be classified as carcinoma, sarcoma, lymphoma, and leukemia, germ cell tumors, and blastoma. So carcinoma are those which are derived from epithelial cells, and most of these common cancers and almost all types of the cancers found in breast, prostate, lung, pancreas, and colon, they are carcinomas. Sarcomas are those tissues which arise from connective tissue, that is those cells, cancer cells that arise from bone, cartilage, fat, nerve. And lymphoma and leukemia are another type of cancer cells or tumors. So they arise from hematopoietic cells, or those cells which are involved in blood formation. They leave the bone marrow and they mature either in lymph nodes and blood. So those cells that leave the bone marrow and mature in lymph nodes are called lymphomas. Those which leave the bone marrow and mature in blood are called leukemia. Germ cell tumors are those which are derived from pluripotent cells and often represent the testis or the ovary. So those which start from the testis, they are called seminova, and those which are generated from ovary cells are called dysgerminova. Blastoma are those which are derived from immature precursor cells or from embryonic tissues. So the common risk factors for development of cancer are smoking, alcohol abuse, tobacco use, dietary habits or healthy eating habits, workplace. So some of these cancers can arise also due to the conditions that are available at the workplace. Radiations, infections, pollution, genetics of the person, age of the person, hormones, so all these factors together contribute to development of cancer in a person. And if you look at uh, the general risk factors for cancer, we see that tobacco use, unhealthy diets, physical inactivity, and harmful use of alcohol, all of these can be causes of cancer. Now, how do these cancers develop? So we have been talking about that the cancer cells originate from a particular tissue. Now the question arises, how is it that a normal cell becomes a cancer cell? So there are certain mutations, certain changes in the genetic makeup that happen, which converts a normal cell into a cancer cells. So those genetic changes, they result in uncontrolled cell division. So what are those? A mutation in error correcting machinery of a cell might cause that cell and its children to accumulate errors more rapidly. So what happens is that when we are exposed to certain chemicals or radiations, the DNA becomes damaged, certain errors start appearing in it. For example, an A may be replaced with T, two consecutive T's, one T and then another T, which are together. They may react in UV radiations or other radiations. So all of these changes, they lead to errors when the DNA is replicated. So there is an error correcting machinery. There are certain enzymes which detect these kind of damages and they try to repair those damages. Now what happens that in certain cases, these damage repairing enzymes, they are mutated, so they don't perform their functions in the required way. So what happens, either their activity is reduced or their activity is completely absent. So the errors cannot be corrected, as a result of which the cell starts accumulating uh, these errors, and all the children cells that are formed from division of this parent cell, they also start accumulating errors more rapidly. Why more rapidly? Because now the error correcting enzymes are not working. So as a result of these accumulation of errors in DNA, mutations start occurring. Now the second thing can be a mutation in an oncogene might cause the cell to reproduce more rapidly and more frequently than its normal counterparts. So there are certain genes that we call as the oncogenes, that is those genes which which stimulate cell division. So what happens is that when these proto-oncogenes, that is those genes which control cell division, they are mutated to what we call as the oncogenes, so these cells start dividing very rapidly. Then the third thing can happen is mutation can cause loss of a tumor suppressor gene, disrupting cell death pathway and immortalizing the cell. The third thing that happens is that when the cells divide, there is always a certain proteins which check the growth of cells. They what we call as arrest the cell growth. That is, once the required number of cells have been produced, the growth stops. So what happens is these checkpoint proteins, they become mutated. So the cell death pathway does not follow the normal pathway. That is, the cell death does not occur or occurs at a very delayed time point. So practically the cells are immortalized, meaning they don't die under normal conditions. So that can also lead to development of cancer. What are the signs and symptoms? Signs and symptoms are not very well marked. a lot of these signs and symptoms can be confused with other diseases. For example, losing weight for unknown reasons, feeling worn out or tired for no reason. There can be lumps in neck, armpit, or groin region. There can be itching all the time, and there may be night sweats. Now you see, these signs and symptoms are also observed in tuberculosis. For example, even in tuberculosis, there is an unexplained weight loss. People are tired. If TB spreads, we see these lumps occurring in neck and armpits. There are night sweats. Itching can occur due to a lot of other disorders, and weight loss can also occur due to lot of other disorders. For example, in diabetes also we see there is weight loss, there is feeling of tiredness. In anemia also we see there is a feeling of tiredness. So there aren't any specific signs and symptoms for cancer. So the symptoms can be local symptoms. For example, those symptoms that occur at a specific body part. So they may occur due to mass of tumor or its ulceration. So what happens is that when this tumor grows in a particular tissue, it pushes the cell around it. So we see that this abnormal growth can lead to certain signs and symptoms appearing. Plus, there is also ulceration. So this ulceration can lead to bleeding and other complications. So those kind of signs can also come. So some of the examples are in lung cancer, the tumor may grow in bronchus. Now that leads to blockade of the bronchus, leading to coughing or pneumonia. If it is happening in the esophagus is blocked, so there is difficulty or pain during swallowing of food. If there is ulceration, bleeding can occur. So if it happens in lungs, the person will produce blood while coughing. If it happens in colon, we see that rectal bleeding can occur or anemia can occur. If it is happening in bladder cancer, blood may come in the urine of the patient. Then there can be localized pain in advanced cancer. So initial tumor is usually painless. So when the tumor mass is small, it is not painless, but as it grows, pain can start happening. Some cancers can cause a buildup of fluid within the chest or abdomen. Now, when these cells grow, fluid can also accumulate at the site where they are lodged. So all of these are local symptoms. Then there can be systemic symptoms, meaning those symptoms that occur throughout the body. So these occur due to body's response to cancer and can include fatigue, unintentional weight loss, changes in skin. So skin may become dry, skin may become patchy, discolored, or kind of similar things can happen. Systemic inflammatory state can also happen, which can lead to muscle loss and weakness. So the person will complain of weakness in muscles, muscle pain can be there, muscle degeneration can also be there due to release of inflammatory molecules. And Hodgkin disease is a type of cancer where we see fever happens. In leukemias and liver and kidney cancers also we see fever happening. Then hormones or other molecules produced by tumors such as hypercalcemia, that is increased concentration of calcium, can cause altered mental state, constipation and dehydration. So when the tumor produces certain hormones that can lead to increased concentration of calcium in blood, we see that the mental state is altered, constipation can occur in the patient and dehydration can occur. In certain cases, hyponatremia can occur due to release of certain hormones and molecules. So hypernatremia means decreased concentration of sodium in blood. So when this thing happens, there is again altered mental state, vomiting can happen, headaches and seizure can also occur. Then certain symptoms can come due to metastasis also. So they depend on tumor location and can include enlargement of lymph nodes, liver or spleen. There can be pain or fracture of affected bones, and there can be neurological symptoms. So depending on where the cells lodge uh, after metastasis, local symptoms can occur there. How do we diagnose it? So initial diagnosis is done by signs and symptoms or through screening. So we look at the signs and symptoms, try to figure out the reasons behind it, and then we do a screening. So this screening can be what we call as a biopsy, it can be blood test, it can be some other test, it can be genetic screening. So one of the common things that that doctors do is biopsy. So what we do here is a pathologist or a doctor will observe the cells under a microscope and try to figure out what kind of cancer it is. And then this indicates what type of cancer it is, histological grade, so whether it is grade 1, grade 2, grade 3, grade 4. So those kind of things we can understand. We can also come to know about the genetic abnormalities that are there, whether there is a chromosomal breakage that is happening or there are certain mutations. So all those kind of things can be studied in biopsy samples, and we can also look at other features. Then we do other tests like blood test, X-ray, PET CT, MRI, endoscopy, etc. So these tests may not always look at the cancer itself, but they can also be performed to check whether there is metastasis happening or not, or what are the secondary effects that this cancer can have on other organs or on the body as a whole. Then genetic testing is also done. Coming to treatments, there are a lot of options available for treatment of cancer. So starting from right is the immunotherapy, where we give some types of antibodies or certain vaccines like BCG to stimulate the immune system so that cancer cells can be killed. Radiation therapy or radiotherapy, here we generally give gamma radiations to kill the tumor. Targeted therapy, in this we simply use certain therapies that target the cancer cells, and they are what we call as local therapies at times, meaning the drug or the treatment is delivered only at the site where cancer cells are there. Then is chemotherapy, the most common use, whereby we give certain drugs for treatment. Bone marrow transplantation in leukemia and lymphomas, the abnormal cells are formed in a bone marrow. So what we do here is we kill the bone marrow cells in the cancer patient, and then we inject normal bone marrow cells from a donor into the cancer patient. So what happens that as this bone marrow develops in the patient, normal cells are formed, so leukemia and lymphomas are cured. Then is surgery. So surgical removal of tumor is there. Hormone therapy is also used. For example, in case of breast cancer, hormone therapy is used. Thank you.